Now I'm glad to invite our first presenter, Professor Max Birchwood. Max is Professor of Youth Mental Health in the University of Warwick, United Kingdom. He's one of the pioneers of early intervention of psychosis, developing key aspects of the scientific rationale, and opened the first early intervention service in the UK back in 1994 in Birmingham, working closely with Pat McGorry in Melbourne. Many of you remember presented last year's. He secured major government investment so that all young people with the first episode of psychosis are now required to be treated through a dedicated early intervention team. There are now approximately 325 teams in the UK. He led the UK's national evaluation of the implementation of early intervention, many of the lessons from which Max will share today. Thank you so much, Max, for being with us today. It's a great honor to have you here with us.
Thank you very much for your kind invitation. And I must say I'm delighted to be here at this extraordinary meeting of the Navigate community. I'm just looking at the numbers of people attending, ticking over on the bottom there. This has got to be the biggest online talk I've ever done. I approach it with awe and some trepidation, I have to tell you. The first thing I'd like to say is that I have admired the creative and innovative way that Navigate has adapted and developed the early intervention model, and in particular, the meticulous way in which you've ensured that those core interventions are delivered to a very high standard. It's so important. I'll come back onto this a bit later. And it's not something that we've always focused on in the UK. So congratulations to you. And it's a really important innovation that you're doing here. As David was saying, I lead the the UK evaluation of the real world implementation of early intervention. And we've been at this a very long time, since the mid-90s. So we've got a lot of experience under our collective belt. And we've had many successes, but I'm going to focus today on some of the lessons that I think that we've learned in the UK, from some of the advances, but also some of the limitations of the model and what that can tell us about how we need to move forward in the next iteration. So this is where I have a slight anxiety attack to make sure that the PowerPoint comes up. Right, I'm really hoping you can all see that. Can somebody give me a thumbs up? Yay, good. Lovely. Thank you very much indeed. I just need to move the pictures somewhere else. Okay, well, the place I'd like to start, how does this move on, is here, which is just to say, this will not be news to you, but this is in my head what it is we're doing in early intervention. We're doing two things, in my view. First of all, we're reducing treatment delay to get mainly young people into effective treatment as early as we possibly can. That's often known as the duration of untreated psychosis. And secondly, once we've done that, we're trying to sustain engagement of these predominantly young people into treatment, into good evidence-based treatment, and to sustain that through what I've called the critical period. This is the first 3 to 5 years where all the prospective studies of first episode psychosis tell us that a lot of the disability and long-term course patterns develop, and often very aggressively in that early period. So, sorry, I'm just having a bit of trouble trying to work out that. Okay, so we started this 20, 30 years ago, and this is the Bible of our implementation guideline. And this is the important thing I want to stress, is that when we developed this model, it was based on the service structure that I developed in Birmingham in the mid-90s. And what we did then was to provide what we thought was the best guess, a hypothesis, if you will, about what the the likely service structure would be that would fulfill the aims that are at the top of this slide. So it was a hypothesis. And it's only through research and reflection that you can then ask yourself whether this hypothesis about this service structure is meeting the aims that you gave it right at the outset. And I'll come back to this again and again. So in the UK context, we developed a model partly because of the very low rate of engagement and mistrust of our young people in our psychiatric services. We did away with all the trappings of traditional services, no outpatient clinics and so on, because no one attended them. And we developed a modified assertive community treatment model. We have a 1:15 case ratio, sustained over 3 years, the so-called critical period. And we very much emphasize psychosocial and vocational interventions. This is what young people wanted. And our approach was to engage these mainly young people in low stigma channels. And to do so, we designed this service in collaboration with young people, because the logic is that if you do not design a service that young people would value and engage with, there is absolutely no point in delivering in doing what you're doing. So this was really crucial, the emphasis on engagement and reducing treatment delay. So fast forward, there've been a lot of trials. This model has stood the test of time. Very pleased that it has done so. And these are our national guidelines, so-called NICE guidelines for management of schizophrenia and psychosis. And central there in first episode psychosis, we are mandated by these guidelines to provide dedicated team-based early intervention in psychosis services to all young people with a first episode of psychosis. And now there are even targets for delays in standards to make sure that individuals receive care within 2 weeks of referral to a mental health service. And I'll come back to that in a minute about why that is. So, you know, we've come a long way, a lot of great success that we've had in implementation. Now, I'm going to, as I say, just be dipping into a few areas where we are learning from success and the limitations of this particular model over the last 20, 25 years. I'm going to argue, first of all, that in the UK, at least, we've tended to neglect the first element of our aims, which is the delay in getting people into treatment, the duration of untreated psychosis. And as I'll show you in a minute, a DUP appears to limit the effectiveness of the early intervention psychosis approach. The second thing, if you accept that, is, well, how do we go about reducing DUP? Is it enough simply to have a dedicated treatment team? How do we do it? And how quick do we need to get people into treatment? How low should DUP be in order for it to make a difference? Those threshold effects have not really been understood. The third thing I want to say is how we maintain the gains from early intervention psychosis over time. This is a critical question, and one that, in my view, has tended to be avoided a little bit, certainly by the services here in the UK. I want to say a little bit about so-called early intervention non-responders. We know that a lot of young people respond very well to this approach and engage with it. But I'm going to argue there are substantial numbers of individuals who don't seem to respond so well. And we need to understand who they are and why, and whether this can tell us how we can inform improvements in the model for the next iteration. And finally, one of my hobby horses, very briefly at the end, I'm just going to argue that perhaps we need to do a lot more to develop phase-specific interventions. You know, the issue is, do we just use standard interventions for psychosis that we apply in the early phase, or is there something about the early phase that suggests that we need to do a bit more to develop interventions that are appropriate to this early phase? Okay, I'm going to draw on this national implementation study, the 2 large program grants we did, where we observed the implementation of early intervention in various socio-demographic settings right across the country. And we had well over 1,500 young patients who took part in this evaluation study. We answered many, many questions, and you'll see some of those will pop up as I go through the presentation. So my first issue is DUP is central to EIP effectiveness. Well, I'm not going to start off with a piece of our own research. I'm going to show you some of your own work, some of the work of the RAISE project, which evaluated and navigate treatment. This is a really important piece of work. And I'm just going to highlight one piece of it. Please don't interrogate the next slide too closely. It's a bit busy, but just you can follow this up in the American Journal of Psychiatry a few years ago. And it's this graph. So as I say, don't try and interrogate that too much. But what this has shown us is two things. One, that the Navigate model was effective over the 2 years of its evaluation. But secondly, it interacted with the duration of untreated psychosis. So those individuals who took a very long time to get into treatment, they were much less likely to benefit from that dedicated early intervention approach. And I'll come back to this in the first half of this presentation. So really very important. You know, it is known correlationally that the duration of untreated psychosis is a predictor of short-term outcome of a response to treatment. And here, this important study showed that there was an interaction between this and the effectiveness of the dedicated early intervention approach, exactly as the in line with the aims I was describing right at the very beginning. So, great. Well, we know that, but how do we go about reducing DUP? There have been a number of efforts to do that. I haven't got time to go into all of those, but I just want to illustrate this with a few points. Okay, first of all, what about the early intervention teams themselves? Does the presence of an early intervention approach itself reduce DUP? And this is the question that we asked in this national effort in the UK here, the National Eden Study. And what we showed in this graph, these are on the right-hand side, these are a lot of teams who came online during the lifetime of the National Eden evaluation study. And we found that in the course of the lifetime of these new teams, in each successive year of their new life, the duration of untreated psychosis actually reduced as the teams became embedded and developed a momentum. Why? Well, it's not entirely clear, but I suspect it's because the flag was being raised about first episode psychosis in the mental health service. And secondly, and relatedly, that the pathway to care was becoming more permeable for these young people as they made their way through services. So I imagine those are two of the cases. So this was a very substantial reduction in GUP over time as these teams got underway. Now, this is another busy slide. Don't interrogate this too much. I'll do that for you. And this is a piece of work that was in the Lancet Psychiatry a couple of years ago, where we looked at the relationship between treatment delay and symptoms in the course of the National Eden follow-up. Now, you kind of might think intuitively that the longer the treatment delay, the poorer the outcome in a kind of linear way. Doesn't seem to work like that. And we found, and in fact, in line with one or two other groups as well, that the relationship between treatment delay and an outcome is curvilinear. In other words, most of the impact of the delay in DUP occurs in the first 3 months, perhaps 6 months. Beyond that, there is a lot of impact of DUP up to 3, maybe 6 months. Beyond that, as it were, there's no difference between 1 and 2 years worth of DUP. Something has happened beyond that time that, further delay in itself, I mean, of course, the delay itself can be very distressing for families, but in terms of the illness, it doesn't seem to have further effect. The implication of this is that how long should DUP be? Well, my view on the basis of this is that we're likely to get maximum bang for our buck if we reduce DUP to somewhere in the 3-month mark. Anything more than that, you kind of get diminishing returns. So 3 months is something that we really ideally should be aiming for. Now, looking back on reflection on how we're doing in the UK, I was rather shocked to find that the DUP in the UK, in spite of everything I've just said, was still rather long. And that if we use the threshold of 6 months, a third of individuals, that's a lot of people, who had very long DUPs. And amongst that third, the average DUP was somewhere between 18 months and 2 years. So still, in spite of all these very mature teams, in spite of all this investment, yes, we were having a very great benefits, but still it was late intervention for a lot of individuals. So in the light of everything I've just said, this is a real problem. And if we're going to make these teams work and do the best for our patients, we've got to get this figure down. Now, in the UK, in our teams, we've not had enough attention to DUP. And I think partly because I think there is a feeling, well, how on earth do you reduce treatment delay? This is a community stigma issue. Is it really something that we've got the levers that we can control to reduce DUP? So the question that we asked, and I think that you'd find this interesting, I hope, is why is DUP so long? Why are these delays? You wouldn't find it so much, for example, in cancer or in other serious illnesses, but there is an amazingly long delay here in psychosis. Now, please do interrogate this slide a bit more closely, and it tries to unpack the sources of delay as people go into treatment. So along the top here, you've got DUP from start to the first treatment. And there are 3 hypothetical component delays. You can imagine that once the psychosis develops, while the family and the individual are trying to work out what on earth's going on, there'll be a delay in individuals seeking help for the symptoms and for the distress it causes. You can imagine that there may be a delay. You seek a first helping contact. There may be a delay in getting into the mental health service, a delay in referral. In the UK, it might be you go to a general practitioner and there may be a delay getting into the mental health service. There's a third theoretical delay, which is once you're referred to that specialist mental health service, do the treatment services get their act together quickly enough to get people into treatment quick? You might imagine that this would be quite short, and this, for example, help seeking delay would be quite long. How wrong we were. Now, this is a piece of work we did in the British Journal of Psychiatry trying to understand these treatment delays. First of all, again, as I mentioned earlier, a third have very long DUP. And we asked, is it because of a delay in help seeking, delay in referral, or delay within services? And our prediction was exactly the opposite of what we found. In fact, the greatest delay occurred within the mental health service. So once individuals were referred into the services, it was like going into a black hole for many individuals. It's partly to do with the structure of the service. This will be different for different service structures, but I think does illustrate the importance of clear and effective audit of the pathways to care. So we were really surprised to see that actually the answer to reducing DUP could be on our own doorstep. So armed with this information, we tried to conduct a study to reduce treatment delay. And part of the problem here is that a lot of individuals, before they got into the early intervention team, while the different services were working out whether it was a depression or a psychosis or a drug problem, a lot of DUP was ticking away, and individuals often disengaged from services very quickly before they got into the early intervention team. Of course, this may vary from structure to structure. So how do we reduce it? Well, I'm just going to show you very briefly a piece of work we did in Birmingham, and this is, focused on this large urban city, in a second largest city in the UK, where we did an experimental intervention to reduce DUP as people went into our early intervention teams. And it was a quasi-experimental study where we did 2 things. Firstly, we developed a new youth access pathway. This was an adult mental health service, and we developed a youth adult pathway for individuals 16 to 25. The reason being that a lot of these young people were disengaging from the service and had disengaged before the early intervention team had got hold of them. The second thing we did is we used an electronic surveillance algorithm to monitor any individuals who were coming into the service, in the generic service, with any kind of psychosis. And also we did a community piece of work to try and reduce help-seeking delay. This was not an expensive, not an expensive intervention, but it was highly targeted to this particular group. So the result of this is that we were able to halve the DUP within the Birmingham area, a population of 1.2 million people, by the way. We were able to halve the delay in DUP, mainly, and if you can see this, by reducing the delay within the mental health services from 124 down to 42 days. So these pathway changes within our own mental health services are some of the levers that we used to reduce DUP. So now this is something I would recommend that you might want to do. Maybe, I don't know, the extent to which this is the forefront of your mind, is to undertake an audit of pathways to care and where the delays occur and which of those pathways are amenable to control and malleable. Okay, so DUP. Third thing I want to emphasize, talk about, is the maintenance of the gains that we've seen in the trials and in the implementation studies we saw in National Eden. How do we go about maintaining these gains? Now, where a lot of the trials, again, don't interrogate this too closely again, but most of the trials that have followed up patients after early intervention, once early intervention has stopped after 2 years or 3 years, once they're followed up 1 and 2 years later, in nearly all those cases, once the intervention is stopped, they go back to baseline. And it's, you know, this is often used as evidence that EI is not effective. To me, this is a highly illogical position, because, you know, you wouldn't say, you know, you stop antibiotics, infection comes back, therefore antibiotics are not effective. No, there's something about how you know, may individualize and think of strategies to maintain change. This is the emphasis in my view. And we've not really confronted what is needed to maintain these gains long term. Now, there are many thoughts on that. I just want to draw your attention to one particular study, which is a fantastic piece of work done by my friend and colleague Ashok Malla in Canada. Many of you here will know Ashok. And what he did was to extend early intervention from 2 years up to 5 years. And the question, and the 5 years is the period that I characterize as the critical period. And he said this was a randomized trial extending early intervention basically up to 5 years and comparing it with 2 years plus individuals who went back into routine care. So this was the question. Very good piece of work, highly recommend reading this. And he found that extending early intervention in psychosis, using, by the way, the very similar model to the one we have in England here, up to 5 years, improved remission by 50%. I mean, this is not a marginal, this is a big impact. And that he also found an interaction with DUP, so that those individuals who came into his service with a shorter DUP, less than 3 months, by the way, had a much greater response after 5 years. So this is really important. We're getting a massive maintenance of change here, but the question still remains. This is an issue I rehearsed many years ago. What happens now after 5 years? If we relax the grip of this early intervention approach, will it go back to baseline again, or is there something that will make these changes self-sufficient? It's a really important question. My view is that, you could think of it, these early intervention approaches only being effective so long as they are active. That's one way of thinking about it. Or it could be that for some individuals, these effects will be maintained at a lower level of intervention, at a low maintenance dose, if you like. We don't know whether that's the case. My view is that we need to think about personalized maintenance interventions. What does this person need in order to maintain the gains that we're doing? This is a complicated area and is really, I think, an important one for us to grasp and to face up to over the coming years. Okay, my fourth point is early intervention non-responders. Can we use this to improve outcomes from early intervention? Okay, another slightly busy graph, but here, this is, again, some data from the National Eden study where we looked at the outcomes, this is in terms of social disability and social recovery, after the first 18 months, or 12, 18 months of early intervention. And yes, we did find, these are looking at different trajectories of recovery. Yes, we did find a group who responded very well and where their social disability reduced over time as our interventions bit. But look at this group here at the bottom. There was a 40% of our group who stubbornly were not responding, who had a very high level of social disability to begin with. And in spite of all our best efforts over a year or two, we're still at that very low level. So this is the old thing, you have an average score for someone, a group's improvement, and you need to look at the subgroups and the details. So we're not doing very well with, 40% is a lot of people. And we need to think about what we're going to do with those non-responders. So what we did here, again, you can read up the details of this. This is a trial that we did in Lancet Psychiatry a couple of years ago, developed in conjunction with my friend and colleague David Fowler, where we focused on this non-responding group and did a motivational intervention, but also crucially, this group had multiple problems. They were anxious, they were demoralized, they had a lot of depression and suicidal thinking. In other words, this is a group of people who'd given up, who felt there was no hope. And this is something that was targeted, or we tried to do as best we could in this trial. So as it were, we were reducing the barriers to change and also providing focused social recovery, CBT focused social recovery in this group based around behavioral activation, coaching, and motivational intervention. And yes, this intervention was incredibly effective. We were able to quadruple the time that these individuals spent in constructive activity. Still many questions that will surround this, but the importance for the present talk is just to emphasize, that you can gain a lot by looking at the, groups of individuals who don't always respond so well. And it's maybe not a group that we're always comfortable in thinking about. Certainly, I found that the case in the UK, but actually the potential benefit from doing so and thinking about how that might inform your further iteration of EI can be very, very productive. Just another example, we found also that in our early intervention teams in the UK, there are lots of, the UK has a lot of social inequalities. And we all know about the impact of social inequalities on health generally and on the rates of psychosis and other disorders. And here we found that these social inequalities were working their way into, were still in operation within our early intervention teams. And our Black and people with Black and Asian heritage certainly doing less well under early intervention psychosis. And that was partly because some of the opportunities linked to deprivation were still rearing their heads and were very prominent as individuals went through their treatment work. So translating this into a remedial strategy, I'm not quite sure, but these are important things to understand when thinking about, how can you make our treatments more effective and make a difference, most importantly, to the life chances of young people. Finally, I just want to fly the flag for phase-specific interventions. Now, I mentioned at the beginning that, what we've tended to do, was how I see it anyway, is that we've tended to think about early intervention as applying standard effective psychosis interventions in a focused and targeted way with the young early onset group, which is fine. That may well be appropriate. The question is, the question we, in my view, not asked so much, is that whether we need to adapt or develop new interventions specific to the early phase group. And this is my last section, be going on for just a few more minutes. So these are my top 5 candidates for phase-specific interventions. Now, in the UK, we talk a lot about NEET status. I know it's not a term that has gone very widely, but it means not in education, employment, or training. And we know in the UK, forget psychosis, if you're not in education, employment, or training by the age of 25, it's a massive social disadvantage. It predicts a lot of employment problems later on, and also a lot of social marginalization, a lot of young people getting into difficulties of one sort or another. So getting people into education, employment, or training, for me, should be the totem pole of early intervention and psychosis services. Can we get people into education, employment, or training should be the litmus test, in my view, of a success of an early intervention approach. And I think you've got Owen Kalaki talking, I think, at the conference at some point, I believe, and he did this fantastic piece of work on individual placement and support adapted and developed for first episode psychosis. This is terrific. We should all be doing this, and it really should be the bedrock of the work we do. And I'm sure it's there amongst your Navigate suite of interventions. So, but not just in itself, its NEET status, is my view, is what we should be aiming for. Second thing is my hobby horse. Over many years, I've done a lot of work on depression and social anxiety in psychosis. And we often have not thought about this too much because we often think of psychosis being non-effective. It's to me, it's a misnomer. And I've done a lot of work with colleagues showing that in over 80% of cases, social anxiety and depression and suicidal thinking precedes, accompanies, and actually follows a first episode of psychosis when it recedes. And that a lot of the problems, you saw it in the previous slides about the non-responders, we need to implement what we know works in depression and social anxiety in this group, and to adapt it specifically for the first episode group. I haven't got time now, but a lot of social anxiety, the content of social anxiety cognitions in first episode psychosis are often to do with stigma, the stigma and what other people might think if they are discovered as having a psychosis. So while the phenomenology and the architecture of the symptoms is exactly the same in social anxiety disorder with non-psychotic social anxiety and depression, the content is slightly different. And this, in my view, should inform further trials and intervention focused on these crucial areas, these really, really crucial areas. And I also have the view that affective dysfunction in psychosis is actually very symbiotically linked to the psychosis itself. This has been a very long-term view of mine. Just the last few slides then. We all know about PTSD. Well, it's another affective disorder, and there have been lots of studies have shown that something like 40%, I mean, that's an extraordinary figure, have in PTSD symptoms sufficient to qualify for a diagnosis. And a lot of these intrusions are to do with the experience of psychosis and also of traumatic early life events that are risk factors for psychosis. There are effective interventions that have been developed eye movement desensitization and reprocessing and so on. This fantastic piece of work by Mark van der Haag, not in first episode psychosis, I don't think, pretty sure not, but this is something that really we should be evaluating in early psychosis and providing absolutely routinely. Again, I may be preaching to the converted here in the UK. This is not done in sufficient quantities. And something I know that Kim will be very engaged by, I'm sure I need no convincing. We did this piece of work that showed that continued cannabis abuse was linked to poorer outcome. This is from the National Eden study in many domains, not just in psychosis, but in mania symptoms, social disability, and so on. There was actually quite a reduction in cannabis use after the first episode, but there's quite a lot of individuals a year later who continued to use it. And this group had a very poor outcome. The implications, well, guess what? We need to have a double focus, a double down on this issue of substance misuse and particularly cannabis use in this group. Again, not very well understood, to be honest, or acted upon in the UK. Yeah, partly because it's so prevalent, I suspect. And finally, we need to embrace technology. I'm sure we all are. Here we are on Zoom, and I'm talking to 500 people or 300 people. Extraordinary. I did a lot of work a long time ago in the 80s. That dates me, doesn't it, about early signs of relapse in schizophrenia. And part of the problem was getting information about these early signs before, quick enough so that the services could deal with it. And now with the advent of the good old mobile phone, you can do ambulatory monitoring. This is not done in first episode psychosis, actually, but was a study done in Australia and with my colleagues in Scotland, where we evaluated this intervention, monitoring early signs through a mobile application and embedding the data that gave into the mental health service in which those individuals were managed. That involved also peer support as well. Not done in first episode psychosis. Relapse prevention continues to be an issue, a problem in our clients. And, all our patients have mobile phones. We need to be doing something like this to make a step change in relapse. A lot of young people don't often come off medication, and this is a risk factor for further relapse. So this is my final slide. First of all, what I've talked about is the importance of treatment delay. We don't talk about it enough, and it limits the effectiveness of our teams. How do we reduce DUP? Well, there are many ways to do it, but I suggest the first thing to do is do a careful pathway analysis. How do the patients get into your service? And what are the delays, and why are they experiencing delays? Really important. You might be surprised by the results. That can inform an important intervention. And remember, we're trying to get people into care quickly, within 3 months, ideally, if we can. That will really make a difference. And maintaining gains, got to think about that now. I'm sure a lot of your patients in Navigate have been discharged. Where are they being discharged, and how are you maintaining those gains? And I'm arguing that we maybe need to extend EIP in certain individuals and think about personalized care. Fourthly, we can learn a lot from those people who don't respond so well to early intervention, and it can inform new interventions. Often it can be difficult to face up to. We always like to think that all our treatments work, but often, they do not, and we can learn a lot from it. And finally, my hobby horse, we need to think a lot about phase-specific interventions in the 5 areas that I described to you earlier. Okay, well, I've probably gone over time. I'm not looking at my clock, which is very naughty, but I hope this has been of some use to you, and I appreciate that a lot of what I've said will have resonances and will be translated in slightly different ways in different service contexts. But I think the core logic of what I've said, I think, is valid in whatever domain you happen to be working in. So, David, thank you very much indeed. And I hope I can now stop the screen share. Yes, I can.